There is something that changes when hip pain becomes part of your daily life. You start making calculations before you go anywhere. How far is the parking lot from the entrance? Is there somewhere to sit if I need to stop? Can I make it through the grocery store or the park or the family gathering without that deep aching starting in my hip? And you start making smaller calculations too. Which chair is easier to get out of? Which route has fewer steps? Whether today is a good hip day or a bad one. And somewhere along the way, walking, which used to be something you did without thinking about it at all, became something you plan around and manage and sometimes avoid if you are over 70 and hip pain has started to shape how you move through your day. I want to talk to you today about something that most people in your position have never heard, and that is this. Hip pain is not one thing. It is not a single condition with a single cause and a single treatment. The pain you feel in your hip when you walk could be coming from several completely different places and several completely different conditions. And the reason that matters so much is that the treatment for each one is different, sometimes significantly different, and treating the wrong thing or treating nothing specifically at all because you have been told it is just aging means years of unnecessary pain and sometimes years of a condition progressing that could have been better managed from the start. I am Dr. Daniel Chen, and today I want to walk you through the most common causes of hip pain. In adults over 70, what makes each one different, how doctors tell them apart, and why getting the right diagnosis is the most important first step toward actually feeling better. Let us start with anatomy, because understanding where the hip is and what surrounds it is what makes the rest of this make sense. Most people point to the outside of their upper thigh or to their buttock when they say their hip hurts. But the true hip joint is located deeper than that. It is where the ball of the femur, the upper end of the thigh bone, fits into a cup-shaped socket in the pelvis called the acetabulum. This ball and socket joint is one of the most stable joints in the body, unlike the shoulder, which sacrifices stability for mobility. The hip is designed to be both strong and mobile, bearing the full weight of the upper body with every step and allowing a wide range of movement in multiple directions around this joint. There are multiple structures, each of which can be a source of pain. The joint itself, with its cartilage and its joint lining. The labrum, which is a ring of cartilage that deepens the socket and provides additional stability. The bursa, which are small fluid-filled sacs that reduce friction between moving structures. The tendons and muscles that cross the hip joint, including the hip flexors at the front, the gluteal muscles on the side and back, and the adductors on the inside of the thigh, the nerves that pass through and around the hip, including the sciatic nerve, which is the largest nerve in the body and which exits the spine in the lower back and travels through the buttock and down the back of the leg and the bones themselves, including the femoral head and the acetabulum. Pain can come from any of these structures, and the location of the pain, its character when it is worst, and what makes it better or worse are all important clues about where it is actually coming from. So let us go through the most common causes one by one. The first, and the one most commonly assumed, is hip osteoarthritis. Hip osteoarthritis is the gradual breakdown of the cartilage inside the hip joint itself. As that cartilage wears away, the bones begin to bear more direct contact with each other. The joint space narrows, bone spurs develop, and the joint becomes progressively stiffer and more painful. Pain from hip osteoarthritis is typically felt deep in the groin or in the front of the hip. Sometimes it radiates down the front of the thigh to the knee, and sometimes it is felt primarily in the buttock. It tends to be worse with weight-bearing activities, walking, climbing stairs, getting up from a chair, and it often improves somewhat with rest. Although in more advanced cases, rest pain develops as well. Morning stiffness is common, but typically lasts less than an hour and improves with gentle movement. Hip osteoarthritis is confirmed by X-ray, showing joint space narrowing, osteophyte formation, and sometimes subchondral changes in the bone beneath the cartilage. Treatment ranges from physical therapy and activity modification through pain medication, joint injections, and in severe cases, total hip replacement surgery, which is among the most successful and most consistently effective. Surgical procedures in all of medicine with high rates of pain relief and functional improvement in appropriately selected patients. The second cause is greater trochanteric pain syndrome, sometimes called hip bursitis, and this is one of the most common causes of hip pain in older adults that is most frequently misdiagnosed as hip osteoarthritis. The greater trochanter is the bony prominence that you can feel on the outer side of your hip, just below where the thigh begins, at the point where several important tendons attach, including the tendons of the gluteal muscles. There is also a bursa, a small fluid-filled cushion that sits over this bony point to reduce friction between the tendons and the bone. Greater trochanteric pain syndrome involves inflammation or degeneration of the tendons attaching to the greater trochanter, and sometimes inflammation of the bursa, and it causes a very specific pattern of pain on the outer side of the hip that is typically worse with walking, with lying on the affected side, with climbing stairs, and with crossing the legs. This outer hip pain is distinctly different from the deep groin pain of hip osteoarthritis, but the two conditions are frequently confused because patients describe both as hip pain, and because an X-ray, which confirms the osteoarthritis, may be present at the same time, leading the doctor to attribute all the pain to the arthritis without addressing the outer hip tendon and bursa issue separately. Greater trochanteric pain syndrome is strongly associated with weakness in the gluteus medius muscle, the muscle on the side of the hip whose job is to stabilize the pelvis with each step, as I have discussed in a previous video. When this muscle weakens, the tendons at the greater trochanter experience abnormal tension and loading with every step and develop the degeneration and inflammation that causes the outer hip pain. Treatment focuses on addressing the tendon and bursa inflammation through appropriate activity modification, sometimes a corticosteroid injection into the bursa, and physical therapy focused on gluteal strengthening rather than joint replacement, which would do nothing to address a tendon and bursa condition outside the joint itself. The third cause is referred pain from the lumbar spine, and this is perhaps the most important and most underappreciated cause of hip pain in older adults. To understand referred pain from the spine, you need to understand how spinal nerves work. Nerves exit the spine through openings between the vertebrae, called foramina, in the lower lumbar spine. These nerves supply sensation and movement to specific areas of the leg and hip. When these nerves are compressed or irritated in the spine, the pain is often felt, not in the back, but in the areas the nerve supplies, which can include the buttock, the outer hip, the groin, the thigh, or further down the leg. There are several spinal conditions common in adults over 70 that can refer pain to the hip area. Lumbar osteoarthritis, where the facet joints of the lower spine are inflamed and arthritic, can refer pain directly into the buttock and outer hip. Spinal stenosis, where the spinal canal narrows and compresses the nerves within it, commonly causes pain and achiness in the buttocks and legs. That is classically worse with walking and relieved by sitting or bending forward. This pattern, pain with walking that is relieved by sitting, is called neurogenic claudication, and it can be almost indistinguishable from hip osteoarthritis pain without a proper evaluation. Disc herniation, where a spinal disc bulges and presses on a nerve root, can cause sharp radiating pain. From the spine into the buttock, hip, and down the leg, the critical point is that pain originating in the spine will not be helped by treatment directed at the hip joint. A hip injection or a hip replacement will not relieve pain. That is coming from a compressed spinal nerve. And this misattribution of spinal pain to the hip joint is a recognized clinical problem that leads to unnecessary procedures and persistent unrelieved pain in some patients. The clue that pain may be spinal in origin rather than from the hip joint itself includes pain that is worse with prolonged standing or walking, but relieved by sitting or leaning forward, pain that radiates below the knee into the calf or foot, numbness or tingling in the leg or foot associated with the hip pain, bilateral symptoms, meaning both legs are affected, rather than just one hip, and lower back pain that accompanies or precedes the hip pain. If any of these features are present, a spinal evaluation including appropriate imaging of the lumbar spine, may be more informative than focusing solely on the hip joint. The fourth cause is hip flexor tendinopathy. The hip flexors are the muscles and tendons at the front of the hip that lift the thigh toward the body. They are used constantly with every step you take, and particularly with activities like climbing stairs, getting in and out of a car, and rising from a chair after 70. The hip flexor tendons, like all tendons, have a reduced blood supply and a reduced capacity for repair, making them more vulnerable to overuse and degeneration. Hip flexor tendinopathy causes pain at the front of the hip or in the groin area. That is typically worse with the specific movements that load the hip flexors, getting up from sitting, climbing stairs, walking uphill, and it can sometimes cause a clicking or snapping sensation at the front of the hip as the tendon flicks over the underlying bone, a condition called coxa saltans, or snapping hip. Treatment typically involves activity modification to reduce the load on the affected tendon, appropriate physiotherapy, and in some cases, imaging-guided injection to support the healing process. The fifth cause that I want to discuss is avascular necrosis of the femoral head. This is less common than the conditions I have already described, but it is important enough that I want every person over 70 with hip pain to be aware of it. Avascular necrosis, also called osteonecrosis, occurs when the blood supply to the femoral head, the ball of the hip joint, is disrupted and the bone tissue begins to die without adequate blood flow. The femoral head, which is under enormous loading forces with every step, begins to weaken and can eventually collapse, leading to severe and rapid joint destruction, a vascular necrosis. In older adults, is associated with several risk factors. Long-term corticosteroid use, which is common in older adults. With inflammatory conditions, chronic alcohol use, radiation therapy to the hip area, and certain blood disorders. It presents as hip pain, often in the groin, that can be severe, and that may progress rapidly, from mild to severe, over months, unlike osteoarthritis, which progresses slowly over years. A vascular necrosis may not show on standard x-rays in its early stages, and often requires MRI to be detected. This is why hip pain that is rapidly worsening or that is severe out of proportion to what x-rays show deserves prompt medical attention and potentially MRI rather than a watchful wait. The sixth cause is referred pain from the sacroiliac joint. The sacroiliac joint is where the sacrum, the triangular bone at the base of the spine, meets the pelvis on each side. Sacroiliac joint dysfunction is a recognized cause of pain in the buttock and outer hip area. That is often mistaken for either hip joint pain or lumbar spine pain. It tends to cause a deep aching pain in the buttock that may radiate into the outer hip or the back of the thigh. And it is often worse with transitional movements, moving from sitting to standing, rolling over in bed, climbing stairs. Sacroiliac joint dysfunction is diagnosed clinically through specific physical examination tests that assess the joint's mobility and pain provocation, and it responds to physical therapy, targeting the stabilizing muscles of the pelvis and lower back, and sometimes imaging-guided injection into the sacroiliac joint. Now let me bring all of this together and explain what a proper hip pain assessment should actually include, because I want you to know what to expect and what to ask for. A thorough hip pain evaluation goes well beyond a single x-ray. And the words, "You have some arthritis there." It includes a detailed history. Where exactly is the pain? What does it feel like? When is it worst? What makes it better? What makes it worse? Did it start suddenly or gradually? Do you have any back pain as well? Any leg pain? Any numbness or tingling? A careful physical examination, including assessment of the hip joint's range of motion, testing of specific anatomical areas for tenderness, examination of the lower spine and sacroiliac joints, and functional assessment of how you walk and how you move, imaging, which may include x-rays of both the hip and the lumbar spine, and sometimes ultrasound, to assess tendons and bursae, or MRI, if a spinal or soft tissue cause is suspected, and sometimes a diagnostic injection into the hip joint itself under imaging guidance which can help distinguish whether pain is truly coming from inside the joint or from surrounding structures by temporarily numbing the joint and assessing whether the pain changes. Now, I want to say something that I think is one of the most important messages of this video. If you have been told you have arthritis in your hip, based primarily on an X-ray, without a thorough clinical examination, and without a detailed discussion of your specific pain pattern, you have not had a full hip pain evaluation. The X-ray is one piece of a larger picture, and the larger picture is what determines which of the many possible causes of your pain is actually responsible, and therefore what treatment will actually help. Ask your doctor, where specifically is my pain coming from? Have the tendons and bursa around the hip been assessed? Could any of this pain be coming from my spine? Should I be referred to a physiotherapist or a specialist for a more detailed evaluation? You have been managing this pain for long enough to deserve a real answer, not just a label. I am Dr. Daniel Chen. If this video helped you understand that your hip pain may be more complex than you were led to believe, please share it with someone over 70 who is also limiting their life around hip pain that has never been fully explained. Subscribe to this channel for weekly videos made with genuine care for older adults who deserve real information about their own health. And leave me a comment below. Tell me where your hip pain is and whether you have had a thorough evaluation or whether you were simply told it is arthritis, and leave it at that. I read every single comment and I genuinely look forward to hearing from you. Take care of yourself. You deserve to walk without planning your whole day around the pain.